Okay, welcome to Chapter 5, Neuro and Psych Pharmacology 1. And what I want to go over are four topics. First, it's going to be a little introduction to neuropsych. Then we'll get right into the antipsychotic agents, then the antidepressant agents, and finally, for just this part, the bipolar disorder agents. So we begin with an introduction, just kind of what is going on in terms of this whole chapter, I guess you could call it. But neurology plus pharmacology becomes neuropharmacology, or studying drugs that affect the nervous system. And the drugs either work on the peripheral nervous system, the PNS, or the central nervous, the CNS. And we'll see how this is important. So in the PNS and CNS, the neurons will transmit information through these electrical impulses, and they'll message one of three cells. Either will message another neuron, or two, a muscle cell, or three, some kind of secretory gland cell. When we're talking about the actual transmission, what happens is that we get a signal, and this is step one, and that signal travels from the soma on the left, moving the action potential to the axon. And if you're watching, this is you see a little animation as the electrical action potential goes towards the axon. But then what happens in step two is developing the synaptic transmission, and I set it up as step 2A, step 2B, step 2C. So step 2A, first, the action potential reaches the nerve terminal. Step 2B, the neurotransmitter releases. And then step 2C, the transmitter binds to the receptor, the postsynaptic cell. And post just means after. Okay? And then neuron, muscle cell, or secretory gland cell. So when we're talking about medications and their targets, medications are either going to cause some kind of axonal conduction, and the drugs aren't really selective. All axons are like the same. So you've got lots of adverse effects with something like that generally. And very few medications inhibit the transmission this way. And we're really talking about the benzocaine, lidocaine, those local anesthetics. On the other side, you've got synaptic transmission, which can be very selective. It works on different synapses, very specific for neurotransmitters. Most of the medications are going to work on this target. But let's see what the 5 synaptic transmission steps are. So the first thing that has to happen is you have to synthesize transmitters. So although this is simplified here, where you've got an A and a B, and they come together as T, the transmitter, this is what happens. The body takes pieces and puts it together to make these neurotransmitters like serotonin, norepinephrine, dopamine, and so forth. But the parts combine to form the whole. The second step is to store this transmitter. And so we've got a little package here. And we package this neurotransmitter into vesicles. When we need the transmitter, there's a release of the transmitter, step 3, and the action potential reaches the presynaptic terminal and causes the neurotransmitter to enter the synapse. Step 4 is the binding of that transmitter. So it's going to reversibly bind. It goes over, does its thing, then comes back. So it reversibly binds to the receptors on the postsynaptic cell. Again, post just means after the synapse or after that gap. And this creates a new action potential. So we get to step 5, which is terminating the transmitter. And it breaks from the receptor, but there's really 3 ways it can go. It can either come back to the terminal that it was at in the first place. It can get degraded by some enzyme, or it can kind of just diffuse into another synapse. 2 of the common local anesthetics that we would use, so this would be that axonal conduction. And again, it's non-selective, and it'll stop the action potential and block the neurotransmitter release. So when you're feeling pain from a toothache, you might use benzocaine, brand Ambisol, and this is an ester type. But when you're using something topically, we don't really worry about its allergenicity or its ability to cause an allergic reaction or something like that. We really worry about that when you have an injectable. So that's why we really reserve benzocaine for something topical. On the other side, you have lidocaine. One example is brand Solarcaine, so when you get a sunburn, you can put this on. This is an amide type, and it's less allergenic. So in addition to its topical use like Solarcaine, we would see this with something like your dentist giving you an injection so you won't feel the pain as they're working on your tooth or something like that. So this is the preferred, especially when we're talking about those kinds of procedures where you're going to need to inject a local anesthetic. So our next group are the antipsychotic agents, and what we do is we divide them into generations. So when you have a first and a second generation, the second generation in some way is supposed to be better. We first name them as first generation conventional or second generation atypical. And the big change as we go from first to second are the movement disorders, which we'll see in just another slide. But the first thing to kind of get down is that we divide this into three parts. You've got first generation, which goes into low potency, medium potency, and high potency. And I'll just talk about the extremes. Chlorpromazine, you would need 100 milligrams of that to do the same thing that haloperidol does with 2 milligrams. Now, I want to be careful because potency is just a required dose. A low potency doesn't mean it's less effective. It just means it takes more milligrams to do the same thing. We'll see why this is really important when it comes to side effects in a second or in another slide. The second generation, which is the atypicals, we have risperidone and quetiapine. So two different drugs in the second generation that are going to probably cause a little bit less in terms of movement disorder, but there is going to be a trade-off, and we'll see that next. So first thing, the first generation antipsychotics, they can block the CNS, acetylcholine, dopamine, histamine, and norepinephrine. And what we really worry about is this blocking of dopamine, which can lead to extrapyramidal effects, or EPS, which can be permanent. So examples include, number one, acute dystonia. And dystonia breaks down into dys plus tonia, so literally bad in muscles. So we're going to see spasms in the back, the face, the neck, and the tongue. Number two is Parkinsonism. It looks like Parkinson's disease, but just shares the symptoms. It isn't really Parkinson's disease. Three is akathisia, which literally means dance if you take it from the Greek, and it's a restlessness. I've heard it called something like you drink a bunch of energy drinks and you just can't sit still, that kind of thing. Not to be confused with akinesia. Now, a kinesiology major is going to study movement. So akinesia is a complete lack of movement. So these are completely different things. So careful not to confuse akathisia with akinesia. Then number four, tardive dyskinesia. So tardive just means late. So if you're tardy to a class, you're late to the class. And the reason it's called tardive dyskinesia is because it comes much later on than this acute dystonia, Parkinsonism, or akathisia, but it also stays around quite a bit longer, and it can be lifelong. So late plus bad plus movement, and one of the movements that you can have are choreoathioid movements, and you might notice the stem, that CHOREO, like choreography. So it's those type of movements where it's something that the patient can't unfortunately control. So which ones are going to cause this EPS? Which are going to cause all of these bad effects? So something like chlorpromazine, which is, again, a low potency first generation antipsychotic, is usually going to cause much more sedation, but the extrapyramidal symptom potential is going to be somewhat moderate. Haloperidol, which is brand Haldol, is going to have a high potency, again, that 2 milligrams to equal the 100 milligrams of chlorpromazine. The sedation is not going to be bad, but the EPS potential is going to be very high. And that's a real concern because then we're going to see these movement disorders that we just talked about. The second generation antipsychotics were an improvement. So we block dopamine 2 receptors and strongly block 5-hydroxytryptamine. You better know it as 5-HT or serotonin receptors. But with less dopamine affinity, a lower EPS risk results. So that's good. We're not going to have the movement disorders as much. And that was the big improvement. However, this generation is known for metabolic symptoms: diabetes, dyslipidemia, weight gain. So diabetes, obviously, and it's a hyperglycemic state, too much sugar in the blood. Dyslipidemia, literally bad fat and a condition in the blood of. So you've got too many lipids in the blood, and we're familiar with LDL, high LDL, and things like that. And then weight gain, which can also contribute to these things as well. So when we're looking at risperidone, brensocatib, quetiapine, Seroquel, we see that this blockade is moderate or low to moderate, and then we look at the EPS, or extrapyramidal symptoms, and we see that they are moderate or very low. That's the real advantage of the second generation antipsychotics. Now, both also produce histamine blockade, but really what we're always worried about are those EPS and trying to avoid those kind of movement disorders. As we move on to the antidepressant agents, we first want to just talk about how we think about neurotransmitters and what we're trying to do. So a very academic way of saying it is a monoamine deficiency hypothesis of depression. So let's break that down a little bit. The monoamines are just a fancy way of saying that norepinephrine and serotonin, two neurotransmitters, are low. So deficiency means low. Hypothesis means we're not exactly sure, but we think this is how it works. And this is our current model. So if someone isn't depressed, we expect that they have higher levels of norepinephrine and serotonin. If they're depressed, we expect that there's less norepinephrine and serotonin in the central nervous system. When we get treatment, we expect these levels to go up. So what we're trying to do is replace these lower levels that aren't necessarily where we'd like them to be. So how do we do that? And as we look at these antidepressants in the next slide, that they affect norepinephrine and serotonin is a little bit hidden, and I'll show you what I mean. All antidepressants work to increase the levels of monoamines in some regard or another. The SSRIs, quite literally, are trying to stop the reuptake of that neurotransmitter serotonin, keep it in the synapse, and hopefully the patient's mood improves. Serotonin norepinephrine reuptake inhibitors, SNRIs, do the same thing, except they affect both serotonin and norepinephrine. Tricyclic antidepressants are named after the shape. So it's 3 rings, tri, and then cycle. So that's what it's trying to talk about, because this was named by chemists a while back. And it hides that the real effect is on serotonin and norepinephrine, just like the SNRIs. But there's some issues with those kinds of drugs. And then the monoamine oxidase inhibitors, again, kind of hiding that this enzyme, monoamine oxidase, affects serotonin and norepinephrine. Again, the monoamine is just a fancy way of saying serotonin and norepinephrine. So if we block one of the enzymes that breaks them down, there's more of it around. And then we've excluded the atypical antidepressant. We'll talk about that when we get to the smoking section, or anti-smoking section, smoking cessation. But these are the main 4 classes. So we want to take these categories and translate them into some drugs. So the SSRIs, citalopram, escitalopram, sertraline, fluoxetine, and paroxetine. And we notice that that oxetine ending is common to both fluoxetine and paroxetine. And that's a little bit tricky, because if we look at the SNRI, we see duloxetine. You can think of duo for 2 neurotransmitters, norepinephrine and serotonin. And that ending is still there. So why are endings in 2 different therapeutic classes the same? Those endings actually come from chemists, and those endings really say that they're chemically the same, which means that sometimes they're not going to necessarily be therapeutically the same. They're not going to do the same thing for the patient exactly. So be careful with the oxetine ending. It can mean SSRI, SNRI, or, as we'll see later, something for ADHD. Venlafaxine is also an SNRI affecting serotonin and norepinephrine. On the bottom left, we have amitriptyline, which is a tricyclic antidepressant. The nice thing is that it has TRI literally in the middle of the drug name to help you remember. And isocarboxazid is an MAOI, monoamine oxidase inhibitor. So those are the four main classes, translating them into the drugs. But let's go over each of the drugs with the PowerPoints so that we have a good idea of how they work. SSRIs are selective serotonin reuptake inhibitors. They bind to the presynaptic terminal to prevent serotonin 5-HT reuptake, which was step 5 in that list. So if serotonin stays in the synapse, it's hopefully going to improve the patient's mood because you have more serotonin around. So again, depression is supposed to be not having enough serotonin. So if we just keep it around, then hopefully it'll improve their mood. And we've gone over citalopram, brand Celexa, escitalopram, brand Lexapro, sertraline, which is Zoloft, fluoxetine, which is Prozac, and paroxetine, which is Paxil. They're all equally effective in treating the depression, but we're going to go see where, based on the timing and side effects, we might want to use one over the other. An SNRI, that's serotonin norepinephrine reuptake inhibitor, it binds to the presynaptic terminal. It prevents serotonin and norepinephrine from reuptake to hopefully improve mood. So there's the two, and there's some caveats with it. So duloxetine or Cymbalta is especially useful with chronic pain. It just happens to work that way. And then venlafaxine, we have to be especially careful. Brand Effexor. It has to be taken with food daily. You can't skip doses. And you would think, okay, well, certainly if the patient is depressed, they want to make sure that they get their medicine every day. But a depressed patient often does things that are self-defeating, might skip doses and things like that. So if you have a patient that doesn't take their medicine as well as they should, something like fluoxetine, which tends to last a bit longer, might be a better choice. The tricyclic antidepressants, something like amitriptyline, these are much less safe than the SSRIs and SNRIs. Works just the same, blocks serotonin and norepinephrine reuptake, so we have more of it around to help improve the patient's mood. That's why it's effective. But it also blocks histamine, alpha-adrenergic blockers, and shows anticholinergic effects. These are really, really difficult for the patient, especially the anticholinergic effects, where you get this dry mouth, some dizziness, a lot of different other effects that we really don't want to see. And the last group, the monoamine oxidase inhibitors, isocarboxazid, which is brand Marplan. These were the first antidepressants developed, but not safe relative to the newer agents. So there's a serious interaction with tyramine that can elevate blood pressure. You can find that tyramine in aged cheese, certain craft beers, certain red wines like Chianti, things like that. And that excess norepinephrine can be really dangerous for the patient. So these monoamine oxidases on the left normally will break down serotonin and norepinephrine. So if we stop the breakdown with an inhibitor, well, then there's more of it around, and that really helps the patient. But again, because of drug interactions, because the possibility of having this hypertensive crisis, we really only see these when most of the other antidepressants have failed. A big thing with these agents is timing. Certain drugs you want to give in the morning, certain it doesn't really matter. Others are going to make a patient drowsy. We want to reserve those for nighttime. So those that would really give someone energy would be sertraline, fluoxetine, venlafaxine, duloxetine. Those that are neutral, citalopram and escitalopram. And those that cause drowsiness, paroxetine, amitriptyline. Those are ones that we really want to give closer to bedtime. Now, something you can do, especially with a patient that has many, many medications, is as you're looking at the chart to see, are there drugs on there for insomnia? Is a patient getting maybe sertraline or fluoxetine at bedtime and it's causing them to stay up. And then we have this medication cascade where we give a medicine to combat the side effect of another medicine. Isocarboxazid is given twice daily, so it doesn't necessarily fall into this group. The bipolar disorder agents, I just wanted to talk briefly about that. Was formerly called manic depressive disorder, and it's been changed a little bit. Patients will experience periods of elevated and depressed mood, but those periods can last for months or even years before switching to the other. So someone might find a depressed diagnosis because it's just been months of depression, but then later this mania comes on where they don't feel like they need medications, and it's somewhat difficult to assess and to treat. We're not exactly sure why this happens. And right now, there's a hypothesis that says, well, genetics might play a role. There might be an issue with the synapses, but we're not exactly sure. One drug that we use, and that's extremely inexpensive, is lithium. And we're not even sure how it works necessarily, but it might affect cell energy metabolism. It might protect the neurons. It requires monitoring because high levels can cause serious toxicity, and then low levels will be subtherapeutic. So we've got a sweet spot in the middle. The issue we have is its relationship to sodium. So if you look on the periodic table and you can see hydrogen, lithium, sodium, and potassium, this is the very far left of the periodic table, and that they are all +1 charges. So the body has trouble telling the difference between lithium, which is a monovalent cation, mono meaning one, valent meaning one electron, is like sodium, so the body can't always tell them apart. And so when the sodium is low, the body's going to hold on to sodium, trying to keep water, but then lithium can be toxic because it can't necessarily tell the difference. So it holds on to sodium, holds on to lithium, the patient's taking their regular dose, and now they're actually becoming toxic.